Okay, now if you don't make it to your seats right now, for the next session, the hips don't lie. I promise I'm going to start dancing and no one wants to see that. Not a single one wants to see that. The alarm was to make sure that I don't start dancing, Saab. Avaras Ashra Mubaraka Niwazma Molaye Molana Ali Nakalam Mubarakna Masi Barakat Laine Bayan Farmayuj. Emma Molana Ali Farmawe che. Talabto Saab, I'm going to mess this up. Will you please say it, Saab? Talabto salama fawajadtuhu fi ibada. Is that right, Saab? Okay, good. Shukran. I sought safety and I found it in ibadat. Ibadat requires various movements on our part, whether it be standing, sitting, bowing, bending, or sometimes even running. These movements are impossible without the proper health of our bones and our joints. To assist us in maximizing our potential for ibadat, SBMAA is proud to present Dr. Mufaddal Gomberawala to educate us on bone and joint health. A few words about Dr. Gomberawala. Dr. Gomberawala is a board-certified, fellowship-trained orthopedic surgeon who specializes in sports medicine, arthroscopy, and the treatment of injuries to the shoulder, hip, and knee. After completing medical school at Baylor College of Medicine, Dr. Gomberawala went on to complete his residency in orthopedic surgery at the University of Michigan in Ann Arbor. He then completed a fellowship in sports medicine and arthroscopy at Northwestern University right here in beautiful Chicago, Illinois. In Chicago, he worked as the assistant team physician to the Northwestern football team. He also worked with the Chicago Cubs and the Chicago Blackhawks. Dr. Gomberawala joined Texas Orthopedic Hospital and Fondren Orthopedic Group in 2015. He is the director of the Hip Preservation Center at Texas Orthopedic Hospital. He instructs trainees and fellow surgeons at Texas Orthopedic Hospital in a variety of courses throughout the country. Dr. Gomberawala is an appointed teaching physician at UTMB, where he serves as clinical assistant professor. Dr. Gomberawala is a team physician for Texas Southern University. He contributes to the medical literature on the treatments of injuries to the shoulder, hip, and knee. So, without further ado, I'd like to turn the stage over to the esteemed Dr. Gomberawala.
Thank you, Zefabai, for that lengthy introduction, and thank you, SBMA Board, for inviting me to this talk. Following two very distinguished speakers, Dr. Ali Bhai and Tasneem Bain, and the hardest talk of the day, by far the one right before lunch. Mola's guidance, support has brought us together. Zefabai, as he mentioned, Mola Satmi Tariq Niwazma in Nairobi, Farmayu. Mola Ali Niwasiyato Masi, Talabtur Salamate, Wajtoho Fil Ibada. એટલે આપને સલામતી કાસી મિલી કે ઇબાદતમાં. હવે આમાં there's two take-home points that Mamluk has taken. One, that we need to keep our bodies strong so that we can continue with ibadat appropriately. This includes namaz, roza, going to Hazrat, sitting in waz. But more importantly, as doctors, how do we do afzal ibadat, which is taking care of other mu'mineen? So I'd like to get the talk started. I have no relevant disclosures, except that I myself am a little low on vitamin D. I'm taking vitamin D3 myself. And unfortunately, I've seen a lot of family members and a lot of friends have issues with low bone mineral density, with osteoporotic fractures. And this is something that's really preventable. And so it's led me and my colleagues to create an initiative for Mu'mineen on bone and joint health. During Shaban, Maulana gave Raza Mubarak, and under Bu Sahiba's guidance, it is being launched through Burhani Medical Idara. The idea is prevention. How do we prevent bone mineral density loss? How do we prevent bone issues? How do we prevent joint issues? It's currently being piloted in Madras, but we hope to expand it internationally. So, what is the prevalence of musculoskeletal disease? As anyone in this room can attest to, it is very prevalent. Orthopedic surgeons have excellent job security, and it's definitely not because of our personality. But more importantly, we're seeing an increase of prevalence in Muminin. More and more of our jamaats are starting to look like this. More and more of our masjids are starting to look like this. Nothing against the bhayo pictured in this, but more and more kursis are showing up in our jamaat halls. And anyone can attest to here, sometimes you can't leave masjid without someone coming and asking you about their knee issue, their back issue, or otherwise. And I think I personally have talked to at least half the people here about their own issues, and please continue to consult me. I'm here for y'all. But really, 1 in 2 adults are not only affected, but actually seek medical care for a musculoskeletal issue in their lives. And the prevalence is extremely high. Over 50 million people, adults, report that they have arthritis. This is just in the United States. Over 75 million people report some sort of neck or back pain. As far as fractures themselves goes, there's 6 million every year throughout the US, and over 2 million of these every single year are osteoporotic fractures. And the key here is 1 in 2 women or 1 in 4 men over the age of 50 will sustain an osteoporotic fracture. And the issue is the mortality rate is extremely high after an osteoporotic fracture. And even if the fracture heals, there's up to a 50% mortality rate 12 months after. Half of the people that have a fracture like this do not recover baseline function. A quarter of them will require some sort of long-term nursing care, and a third will end up fracturing the other hip. We see similar issues after vertebral compression fractures. It can lead to chronic pain in the back, loss of height, a stoop posture. It starts to affect many activities of daily living, including pushing, pulling, lifting. And something that we all have strived to create is a lifestyle of independence that can really affect that. So how common is osteoporosis? If you look just in the US, where we think we have the most advanced medical care, 70% of people over 65 that have osteoporosis don't know they have it, or they haven't been screened for it. So this is a problem. Annual incidence of osteoporotic visits really trumps heart attacks, strokes, breast cancer. And what happens with osteoporosis is a loss of the normal bone mineral density. So bone is composed of the harder outer shell, or the cortex, and the inner trabeculae, and over time that tends to weaken. As that weakens, the force that it supports tends to decrease, and small falls, small trip and falls that would otherwise just be a bang or a contusion actually turns into a fracture. Bone continuously turns over time, and it's an imbalance that causes the osteoporosis. Try not to bore you guys too much, but basically osteoblasts put down bone, osteoclasts resorb bone. This turnover normally happens over time, but what can happen with osteoporosis is that network of structure weakens and causes the bone itself to weaken. What we don't know is what the actual incidence is in muminin and muminat, but there's a few risk factors that increase the risk of developing osteoporosis. Specifically in muminin, we see some issues with fragility fractures in the first-degree relative. That's a very high risk factor. Some people have low body weight. Asian postmenopausal women are at high risk as well. And low physical activity, which some are more guilty of than others, myself included, can sometimes lead to this. There are other medical conditions that, as medical providers, we need to watch out for that can increase the risk of osteoporosis here as well, and certain medications that people might be taking just as part of their normal health. The key here with bone mass is as we grow from birth through life, our bone mass increases until about our 30s, and through our 30s and 40s is when we reach peak bone mass, which is developed or comes in from 3 different factors. One is genes, our genetics that we're given, one is nutrition, and one is exercise. And the stronger someone's peak bone mass is, the lower the curve will be as they reduce their normal bone mass over time. So one of the key prevention initiatives as far as osteoporosis and bone mineral density has been to maximize someone's peak bone mass with time. There's 3 different things that can really contribute to this: calcium, vitamin D, and weight-bearing activity. And calcium and vitamin D are 2 main molecules and 2 main portions of bone health that have really gotten a lot of interest in the last few years. Really targets for prevention. As far as calcium goes, the majority of the body's calcium is stored within the skeleton itself. The majority of calcium we can get through dietary sources, using a lot of dairy, using a lot of vegetables. And it's required that people should have about 1,000 to 1,200 milligrams of calcium every single day, either through diet or supplements. The body can only absorb about 500 milligrams of calcium at a time, so there are supplements that should be divided up along with what you normally eat. And you can take too much calcium. Really, over 1,500 milligrams a day is considered too much. People's calcium needs tend to change with time, and this sort of mimics the graph that I showed earlier, that as your bone continues to grow, you want to create that peak bone mass, and then as time marches on, as our bone mineral density decreases with time, that's when we really want to increase our calcium uptake. There's two different types of calcium supplements, calcium carbonate and calcium citrate. The biggest difference is calcium carbonate can be a little riskier to take because you need stomach acid to dissolve it, and our stomach acid decreases with time, so a lot of people end up taking calcium citrate. I know this is kind of boring. This is by far the longest talk I've given that doesn't have the word surgery in it, but I'll try not to bore myself and try to keep you guys engaged. So vitamin D somehow has become controversial, and I'll explain that somehow here in a little bit. So one of the keys with vitamin D, it helps the body to absorb calcium. It's been implicated as its effects in multiple organ systems, and only about 10% of vitamin D can actually come from the diet. I'm not going to simply bore you with this slide, but some of the majority of vitamin D comes from direct sun exposure, and about 10% of it comes from the diet itself. Vitamin D deficiency has been linked to a lot of different medical issues: low immunity, anxiety and depression, chronic pain, hair loss, decreased endurance, and even wound healing issues. It has been linked to colon cancer, prostate cancer, and breast cancer, and vitamin D tends to lessen with a few different factors. A few different age groups have been identified as potentially high risk for losing their vitamin D over time. In particular, for women, having less sun exposure due to cultural reasons, having a darker skin, and not having as much physical activity, all three of which increase our risk of lower vitamin D. So we are at a very high risk group for low vitamin D and vitamin D deficiency. They studied vitamin D levels just across all comers in India. 4,600 participants were just screened over 229 sites in just around the country. Anyone guess what the number of deficient and insufficient percentage was? 80? Anyone else? 40? 90? Pretty close. 76% deficient or insufficient. And that's somewhere where we get a lot of sunlight, but for these reasons, the vitamin D levels were extremely low. And what was interesting is that half of them were vitamin D deficient, 26% were insufficient, but the highest incidence was in that key group, 18 to 30 years old, when we're supposed to be putting down our peak bone mass. That's where the lowest incidence was. Different manifestations of deficiency and insufficiency, most importantly, bone pain, joint pain, muscle weakness, and actually not just fragility fractures, but your risk of just falling. Falling from a standing height increases with low vitamin D. So part of our initiative is to educate. Part of it is presenting graphics like this. Again, this initiative is very much in infancy phase, but how do we educate people about the potentials with vitamin D deficiency? So vitamin D deficiency has been directly related with low bone mineral density and low calcium as well. But it's also been has a relationship between fractures themselves, as well as low vitamin D can increase your risk for cardiovascular issues as well. Having a low vitamin D status directly affects your risk of developing a hip fracture in 10 years. And if you look at someone who has a high vitamin D level, their risk over 10 years is 7% over the age of 75, and it goes up to 20% in that low vitamin D risk. So this is why vitamin D has been such an important target to prevent bone loss. One of the best ways to naturally increase your vitamin D is direct sun exposure. And by direct, I mean even in the room next to a window, you just don't get that direct sun exposure. So 20 to 30 minutes a day, actually outside, ideally 3 to 4 times a week would be ideal. And then through diet. There are some dietary foods, mushrooms, eggs, butter, tuna, that can really increase your normal vitamin D levels. And then there's some questions about screening and about supplementation. Does anyone here routinely screen or supplement their vitamin D patients? We've got a few hands. Hopefully that'll increase over time. And the treatment recommendations, anyone who's vitamin D deficient really should begin vitamin D supplementation. People who have a lower insufficient vitamin D but aren't deficient, if they have an increased risk because of low sun exposure, their religious or cultural dress, or if they have dark skin, so us, or if they've had a fragility fracture or high fracture risk, those should be considered for vitamin D treatment. It is very safe to take. Some people will take anywhere from 3,000 to 5,000 international units a day, oftentimes available as an oral supplement. Really 3,200 units a day or more is considered sufficient to really increase vitamin D levels. And it has been very safe to take. Toxicity, primarily hypercalcemia, can start to happen if you take 10,000 international units a day or more, and really over 50,000 international units a day, which is 10 times or 20 times more than what the recommended dose is. So it's by far and away been a safe supplement to take. There's a lot of benefits of it that have been proven in the literature. There's not just a risk of fracture, but just a risk of falls gets reduced by 20% in the elderly. There's, of course, a reduced risk of hip fracture and non-vertebral fractures, 15 to 30% in both. There's a reduction in mortality, slightly reduced relative risk from 1 to 0.94. But really, interestingly, in patients who have heart failure, there's a significantly increased reduction in mortality with vitamin D supplementation. So the question is vitamin D screening. U.S. Preventive Task Force actually came out with a statement that they've revised over the last few years that there's not enough evidence to routinely screen in the community people for vitamin D. I present a lot of evidence that I feel is important to screen vitamin D, and especially the recommendations by far and away routinely show that people who are considered at risk are the ones that should be screened for vitamin D, which has been defined as women over the age of 65, postmenopausal women under 65 with risk factors, men over 70, and those that are at a high risk of developing low bone mineral density, which again, that's us. So again, part of the initiative is information like this. This is one of the things that's coming out of the initiative, just in education, as well as offering bone mineral density and vitamin D screening to people that might have risk factors for it. And then the last most important key is weight-bearing activity. There's a law in bone itself called Wolff's Law. The idea here is that bone responds to stress. So the more stress you put into an area, the more the bone responds to it. And so the more weight-bearing activity you put, just naturally the bone tends to reinforce itself around it. And because of this, a lack of activity, specifically weight-bearing or resistance activity, can significantly increase our risk factor of low bone mineral density. And repetitively loading the bone with some sort of resistance exercises, even strenuous walking with weights, using a few weights in the gym, can make a big difference as far as increasing our bone mineral density. It has been clinically proven weight-bearing exercise proven to improve bone mass in people over 70. High-impact exercises in our early years of life, and those key years between 18 and 40 tend to increase bone mass. And balancing, strengthening just itself with the weight-bearing exercises also decreases our fall risk. So this has been proven, like as I mentioned, resistance training over 2 years improves bone mineral density in the intertrochanteric region of the hip, lumbar spine, the overall hip, as well as the whole body. The amount of hours a day you spend sedentary significantly increases your risk of falls, and it decreases, of course, the more active you are. And every 10 minutes of additional moderate to physical exercise can reduce someone's mortality throughout the population by 7%. So there's a very direct impact in decreasing some of the issues that we see with osteopenia and osteoporosis. Once osteoporosis develops, it's really too late. It is a silent disease, and sometimes we don't identify it until it's too late and someone's come in with a fracture. It is the most common issue in humans, and early diagnosis is key and early treatment is key. We're in the Midwest today, so just a study of 4 health systems in the Midwest showed that people that came in with a hip fracture, only a quarter of them ended up actually getting bone mineral density testing. Less than a quarter were actually given supplementation, and only less than 10% were given medication to treat their osteoporosis. Osteoporosis screening has been recommended by all the societies on the right, in particular in postmenopausal women and any adult that's had a fracture over the age of 50. And for this reason, the same U.S. Preventative Task Force has recommended osteoporosis screening in those same groups. So anyone, any women over the age of 65 or anyone under 65 that is at risk, including having a prior fracture. I'm going to blow through this treatment because it's super boring. I'm sorry, it just is. One of the best ways of screening is a dual energy X-ray, what's called a DEXA scan. It actually looks at your bone mineral density and compares it to a statistical population to show if you're normal, osteopenia, or your bone density is becoming lower, or actually defined as osteoporosis. Indications for treatment vary depending on who you're looking at, but basically if you have risk factors, even an osteopenia category, you should start to be treated for osteoporosis. There's a variety of different treatments that are available for osteoporosis. By far and away, the most common of them is bisphosphonates. And bisphosphonates have been proven to decrease fractures with taking them. And that's been shown in multiple studies for both vertebral fractures, hip fractures, and other osteoporotic hip fractures. The biggest issue with bisphosphonates is they have very poor adherence. So only 80% of patients that are given a script decrease taking it. For one reason or another, they just stop taking the medication. One of the primary reasons is it's associated with a lot of GI discomfort, so people do not like taking it for that reason. It's also been ironically associated with muscle or joint pain, and they'll stop taking it. There are adverse reactions that one should be aware of, especially if you're discussing it with your patients who you're initiating treatment. Osteonecrosis of the jaw, so for the dentist here, I'm sure you're already asking for it. And some type of femoral fractures, specifically subtrochanteric fractures, can occur if you take it for too long. So every 5 years, you want to review their medication, put them on a drug holiday, and then restart it. A newer medication that's really gained a lot of popularity is a monoclonal antibody called Prolia. This similarly, over time, in the first 3 years, then an extension of a study into 10 years, had shown very reliable anti-fracture efficacy for both hip fractures and non-vertebral fractures. So people that took it for 7 or 10 years had low fracture rates, increased bone mineral density, a reduction of bone turnover, and there was no increase in adverse events as they continued to take it. One of the biggest issues here is as soon as you stop taking it, all that turns back. So all the bone mineral density markers tend towards the negative within 3 months of stopping it, and your bone density itself tends to drop within 6 months of stopping it. Similarly, vertebral fracture risk increases when the medication is stopped, so it's something that we need to continue lifelong. So to summarize, 3 building blocks that are essential in building up our bone health and maintaining our bone mineral density: calcium, vitamin D, and weight-bearing activity. It's important as medical providers that we identify risk factors for screening, and those risk factors are prevalent in the Mummian population. As we're discussing these things with our patients, we want to educate them about diet and about active lifestyles, as well as initiate those treatments amongst ourselves. And we want to be familiar with low bone mineral density management. If we start to notice people are being affected by it, especially if someone starts to discuss either a vertebral fracture with you, a hip fracture with you, or discuss it within their family, these should all be key factors that really clue you into, hey, this is a point where we can really take a preventative initiative. Ideally, we hope that this rolls out throughout the country and throughout the Alami Iman. And as we see that, I hope to recruit you guys in helping us identify people that are at risk, spreading the word, increasing awareness, and setting up these density screenings. As I mentioned, it is happening through Burhani Medical Idara currently. And I'm here partially to sell the idea to SBMAA. One of its directives are preventative care, and I think this falls directly within that. Chele de shukur to Akamola, through Mola's guidance and support. I mean, we are all here, some of the best doctors in the country, and we thank Mola every day for his continual guidance and support. My contact information for those that don't have it. Sorry,
Wonderful
it's boring.
talk. We've got a
I know
couple
it's a
of
boring
questions.
topic, but
Thank you.
here we are.
Mufaddal, I have a quick question. What if somebody starts late in following through this? How much of an impact will it have?
So that's part of what we've seen with bisphosphonate treatment, Prolia treatment. It really decreases your risk of fractures. And vitamin D treatment itself can decrease not only just other cardiovascular risk, but also just the risk of falls itself. And so while it's never too late, earlier is definitely better, because in my opinion, once that hip fracture happens, and we may have family, friends, or patients that have unfortunately passed after a hip fracture, it's way too late.
But when you say earlier is better, or specifically with regards to calcium and vitamin D, how early?
So when the peak bone mass is being put down, between 20 and 40, so really a lot of us are already after it. We spent most of our 20s inside school studying for medicine, so that's the point where we should be participating in weight-bearing activity, keeping up with their calcium, keeping up with their vitamin D, which might be one of the reasons why vitamin D levels are so low, just in general amongst the Indian population.
You have a follow-up for that?
Sorry. So even if you're 60 and you start, is it helpful?
Very helpful, yes.
Quick question. If your vitamin D levels are normal, would you still take it?
So excess vitamin D gets excreted, and the risk with vitamin D is really tenfold of what someone's normal dietary intake is. So it's low risk to take. That being said, if your vitamin D level is normal, that's where you want to be. And so then you want to ensure that you have the other sort of aspects of it, ensuring you're getting adequate sun exposure, ensuring that you're keeping up with weight-bearing exercises. Same with calcium. So actually, that's incorrect. So calcium is very well regulated, and so high or low calcium levels in general in bone can be regulated pretty easily. So a normal calcium level can sometimes be tricky. And so you just want to be careful of that. Just a low calcium level doesn't mean that you're out of the woods.
Okay.
You know, I have a few questions, please. You had mentioned that you would prefer to see more people doing routine screening. I'm an OBGYN. I routinely add vitamin D in my annual health check labs. Unfortunately, insurance doesn't cover, and some patients come up with a value of 7, 5 young ones.
Correct.
So I hope that changes. The screening requirement, the actual reality requirement is way more than that.
It's way more than that. And that's why I spent 20 slides showing all the effects of vitamin D, and yet the U.S. Preventative Task Force says there's not enough evidence.
Yeah.
That being said, we know people who are at risk. We are at risk. And so part of the initiative too, eventually I might request some of you guys that have labs or have connections with labs is try to get some of this, at least for the community, when we start screening. You're absolutely correct. Because of the task force guidelines showing that population-based screening is not effective, a lot of insurance companies aren't covering it.
They don't even cover bone density unless specific, I mean, forget vitamin D levels only.
There we go. Coding expert.
Okay, yeah, I mean, that probably is true. Yeah. And then, can a patient take 50,000 units weekly for
Correct.
a long period? I mean, I don't know how long, but...
So as long as you're keeping up with their levels, as long as you're routinely checking them, ensuring that they don't go sort of too high, there is a higher limit of normal, then I think it's safe to take. And one of the thoughts too, so actually in the UK what they do, they don't cover vitamin D screening because their population has so much vitamin D deficiency that there's no point screening, just start it. So they'll cover vitamin D treatment and supplementation, but won't cover the screening. So that might be something to consider as well. But then again, you risk over-treating vitamin D by not knowing what the level is at baseline.
And tell me if I should change this. I don't tell my patients to take 1,000, 2,000. I tell them straight 5,000 for a maintenance daily.
That's what most people do. 3,000 and above international units a day is ideal. 5,000 is readily available. Amazon, CVS, GNC. So.
After Ashidabin will be Amr. I think Amr Bhai had a question. Right?
Yeah, I'm a pediatrician. So in COVID, a lot of kids have been, we have been screening because of this fatigue and all those things. And we see a lot of vitamin D deficiency. Same thing, it's not covered, and a lot of patients came back and they had to pay for it. So if you put a fatigue code in it or some kind of a code, then they cover it. So on those patients, how long do we treat? She's saying about 6 and 7, but we usually have 10, 15. That's the thing we were getting that level. And so how long you would say that if we are treating, do we do a high dose at one time, or we just put out 3,000, 4,000 unit for about 3 months or 5 months? Because again, it's not covered to repeat it, so I usually don't repeat.
Yeah, which is strange because once you think that you give them, once they've been diagnosed with vitamin D deficiency, they will let you retest and it be covered. That being said, most people will put them on either a daily or a weekly supplement and then recheck with annual labs, even if it's not covered.
Annual labs.
And even before then, just recheck it 3 months to see if it's made a difference or not. There's some people where even 5,000 international units a day doesn't even touch their vitamin D level, and their levels don't budge, which lets you know that they might need to go even higher or start taking a weekly dose, or they're not compliant with it, which is one of the issues with weekly doses. People just forget.
Yes. No, usually you do it, I think, every day for about 3 months or so.
Compliance is a little bit better with daily as opposed to weekly.
Thank you.
While Josefa is walking over, can I ask a question? Would that be okay?
Absolutely.
I get a lot of pushback from my patients for taking calcium supplements because they're concerned about vascular calcification. Our data does not suggest a correlation between calcium supplements and vascular calcification, but I'm wondering what your data suggests because you have much more about it, much more data than we do.
We're bone docs. We don't know anything about the heart, except it provides ANSEF. So as far as calcium, there is an upper limit. 1,500 milligrams a day has just been recommended. Beyond that, you can get into some of the realms of hypercalcemia. So calcium is the one you want to be a little careful with supplementing. Vitamin D, the ceiling of upper limit is so high that you have a lot more room there. And in fact, just supplementing vitamin D, which is the key to calcium absorption, might be what someone needs to get their calcium. So that might be one thing to consider. And the other thing that was always shocked with is a reduced risk of cardiovascular just events with vitamin D supplementation.
And a reduced risk of statin-induced myopathy.
I don't know what that means.
Yeah.
Can I ask Dr. Divan to just for a second clarify his statement? Because I know that this is a big problem in primary care, that we just don't get the insurance coverage to when we order these vitamin D screening tests. So you had mentioned something about that. Could you clarify that first?
It's not an uncommon issue. I mean, if I have, for example, if I have an HIV patient and I'm ordering vitamin D levels, they'll say, well, what are you ordering vitamin D levels for? So I have to put in a code. If I put in a B20 code for this condition, I have to figure out what the code for osteoporosis is and put that in. So, I mean, the test costs around, I think, $250 odd or so.
It can, yes, if it's not covered.
Yeah, so that's one of the reasons. You can look it up.
We'll look it up. We'll look it up. We'll look it up. Yeah.
One more question I have for you, because I know about as much about this as you claim to know about the heart. Patients come oftentimes to ask me and want to get their vitamin D levels tested. And on my EMR, I try to pull up vitamin D, and there's about 5 different tests. There's a 24-25, and a 21-25, and a 22-23, and I don't know. Can you explain or suggest what the best screening test would be and what the best form of vitamin D supplementation would be?
So the most metabolically active is D3, and so that's the one you want to test for and the one you want to supplement with, generally. D2 supplements are available, which does the trick. It just needs to be metabolized to D3, but D3 is generally the one.
Vitamin D3, right?
So there are kosher/halal/vegan supplements available, and if you, no plug, but if you search on Amazon, that they're there. If you guys have any issues finding them, just text me and I'll be happy to send you the ones that I've taken and recommended to people up top, if you know what I mean.
DECARA, DCARA. That's a 50,000 unit treatment.
Just one 1 second. We want to get it in the mic, so it's recorded.
If you don't mind.
I'm just curious, a pilot project now, what have we found out? Because, I mean, whatever these conditions are existed before as well.
Correct.
But why are we seeing more and more movement on chairs now? Is it just the ease or what's happening?
Yeah, it's a good question. One, I think are, not here, but just in general, lifestyles have changed for the worse. People have become a lot more sedentary. And younger generation has become overweight as well, and we're seeing some of the effects of that already. We're seeing younger people in chairs. There's again, not to judge anyone, some people do it as a convenience factor, that's besides the point. Another point is that, frankly, our advances in medicine are leading to longer longevity, and so the cardiac systems, infectious disease systems, all these are very well managed, and so now we're just left with bad bones. And so there's a matter of treating that, improving mobility, improving motion, improving bone mineral density. These are all the sort of preventive factors that keep people moving. And starting that from a young age is one of the ways that we can just keep that from happening.
But this is
so, and this is just like being started. So like, you know, in Dawat now, like I started this shortly after Ashara, multiple Arziz, and it's just like, so now the pilot project is getting started. It's taking slower than any of us would like. So we don't have any information yet. We're just getting it started. I was hoping to have like a big vitamin D screening camp in Ashra and stuff like that. I don't know if that's going to happen this year, but inshallah.
But this isn't really about chairs, right? I mean, hip fractures are one of the most common causes of mortality in the elderly population. So this is really not just about a convenience or a cosmetic or an issue. This is a true life and death situation. Can you give some, I'll let you comment on that, but can you give some practical exercises that somebody who might be at risk, let's say they're older, they haven't paid attention to this their entire life, and you mentioned weight-bearing exercises repeatedly. What practical types of weight-bearing exercises could help strengthen particularly the muscles and bones and joints around the hip that would prevent these trochanteric hip fractures?
Yeah, so generally it's any sort of weight-bearing, even if it be 5 or 10 pounds. Even using resistance bands in the whole body. So you want to work on the shoulders, you want to work on the arms, you want to work on the legs. At some point, even as part of this initiative, exercise sort of having people come in and show people how to safely exercise might be a part of it as well. And I think that would be a very important thing to show people, okay, this is, if you're saying I have low bone health and my bones are at risk of fracture, now you're telling me to lift weights, that doesn't make sense. So how do we clarify that and ensure that people are lifting safely as part of the education initiative we need to take? And yes, you're absolutely right. It's not about chairs, but we're seeing it. And as physicians, we know sort of this is an endpoint, and people got to that endpoint somehow. And there's some steps that we can take beforehand. It might be 20, 30, 40 years beforehand that we can take.
Phil, do you tend to use the FRAC score to further risk stratify after the DEXA? Because I don't think.
Yeah, I blew through that slide because people were doing some joka. But yes, there are different scores to identify what your risk factor is, and so you can plug it in. And I'll have to go through the slide somewhere. But I think it's American Bone Health has a risk factor score, so you can identify actually for you or for your patients what your 10-year risk fracture score is. And if you're at moderate or high risk, that's one of the objective tools you can use to identify them as either a screening candidate or a treatment candidate. And those scores have been mentioned by multiple of those societies that I showed. So someone that might be below 65 but has a high risk based off those scores. And eventually we might see a point where those scores are tied into insurance reimbursement if you've documented it or something like that.
I have a question. Bisphosphonates, you said you give a drug holiday. How long is that typically?
My endocrinologist does.
Okay.
So just as an example, we have like our practice of orthopedic surgeons is a full-time endocrinologist. So anytime there's even like a whiff of something wrong with their bone health, just directly send them over.
In my practice, I typically give my patients a drug holiday of at least a year.
Oh wow! I'm gonna guess a month.
I usually do 1 year. So we'll do 5 years of bisphosphonate treatment and then a year off.
Do you recheck their DEXA?
I usually I try to recheck the DEXA, but we don't always get there because the insurance doesn't always like to pay for it.
It's just that concept is like so crazy. We see these mortality scores. People want value-based health. They want preventative health, and this is one of the things that we can do, and just with little support from the insurance company. But that shouldn't surprise anyone.
This is one of the leading causes of morbidity and mortality.
Correct.
They're not paying for the screening.
Correct.
We have a question up here in the front.
But they'll pinch us for anti-kickbacks in a heartbeat.
Just make sure you don't own your own DEXA scanner, right? This
On one of your slides, you said 25% of patients who experience a fall and get injured, after that they don't receive vitamin D testing or any scans. Is that due to not prescribing those tests, or the patient having problems?
In that they were never prescribed. So it wasn't as much a compliance issue. So just for example, someone has a hip fracture, we fix their fracture, they go home, go to long-term nursing, follow up with their primary care, just somewhere someone drops the ball. As orthopedists, one of the things is like, it's not just a broken bone, but what's the issue around it. So our American Academy of Orthopedic Surgeons has really taken initiative in the last 10 to 15 years with the thing called Own the Bone. So if we're going to be the orthopedic surgeons, we need to own the whole thing. And so it's been drilled into our heads that as soon as you see it, we should start screening and advancing for it, to the point that even if someone comes in with a distal radius fracture, just had a fall from standing height and broke the wrist, that alone increases the 10-year risk of a hip fracture down the line. So even from back then, we need to think that like this person's at risk, and we just start screening and talking to them about their bone health from that point.
I do want to comment on that. That's an important point as well. We mentioned quality, our quality scores and all this quality stuff that's going on nowadays. With a lot of the newer Medicare Advantage plans that are out there, we are getting scored for our quality based on the principle that if a patient has a fracture, a hip, knee, whatever, anything, any kind of fracture, they need to receive a bone density scan within a year following that fracture. And so we're laughing about the insurance companies don't like to pay for things, but this is an important quality measure that Medicare has actually put forward just in the last year, or 2 years, I think. And so they are starting to rate us on those criteria, and they're starting to pay for bone density tests and vitamin D screening for patients that have had hip fractures. So after the fact. It is after the fact, you're right. Absolutely, but it is happening. So.
Question over here.
Do you have any suggestions on how to help the older population in the Jamaat actually take all of this seriously? Especially, I see a lot of the older aunties, you ask them to do any kind of exercise, even whether it's just take a 5-minute walk outside, and it's just like, no, why would I do that? Do you have any suggestions on how we can improve just getting people up and about a bit more?
And that is, again, we attribute all things to Maulana. So in October, Maulana did bayan about walking. So just a simple walking initiative that SBMA really took into heart, and I think some of the data was presented, was it 13 times? Yeah. 13 times walking. So these are sort of initiatives that don't even just come from us, but come from even higher up. One of the things is this, and if we keep our niyat Allah. So our niyat Allah is to always be able to participate in namaz, be there for roza, be able that we can go for ziyarat without having to be taken in a wheelchair. So these are all the things that we want to accomplish in our late years, and we hope that other people would want to accomplish as well. So sometimes it might be discussing it from that perspective. One of the pushbacks that sometimes people give is then they have some sort of knee issue, knee pain, back pain, or that sort of thing. And so finding ways to treat that, finding ways to treat the symptoms, or just understanding that you have to push through that, you have to maintain that motion, maintain that muscle strength to get there, which is not something unique to, for lack of a better term, just our aunties. There's an entire population of patients that we see that just struggle with that. How do I push through the pain? Some people just don't want to. That's a non-answer, and I know it's a non-answer.
Nothing else works. You can show them that slide of the different bone marrows.
The bone marrow slide should help.
That was remarkable.
And then what's always interesting is And some people will ask for steroid injections. And a one-time steroid injection into the joint, potentially just to encourage them to do this. And if people talk to me about their steroid injections just with an exercise program, that's the key. A steroid injection has to be mated with an exercise program. Let's take advantage of the steroid. Because that alone can also increase your risk of bone mineral density loss. And of course, you go down a pattern of repetitive injections, and so you have to take advantage of it. So sometimes it's just some bargaining. And we see sort of a big fitness drive too in other regions. For example, you walk on Marine Drive now and you see people running, like Indians running up and down Marine Drive, which before was like you'd never see that. And then recently in Kenya right now, we saw like a group of people on the road bikes, as if we were in the middle of Chicago. And it was just like the physical fitness interest that is evolving through the globe is great. We just have to get everyone involved.
So, wonderful talk, and very excited for this initiative.
You have to say that, though.
And very excited for this initiative. One of your slides mentioned that when you studied people in India, and that majority, like 85% of 20 to 40-year-olds were deficient or insufficient. With your initiative, do you have plans of initiating this not just in the elderly and 50 and above or 65 and above, but also I would encourage concurrently for those 24, for multiple reasons, as that seems to be the best time to truly prevent.
Correct. And it's interesting you mentioned that, because when we first presented it to Indian doctors, their pushback was, we don't need this. And it's like, so here's all the data points just for low vitamin D that you do. I showed some studies, of course, with my bias. There are some studies that also show that vitamin D treatment is not linked to any changes with cardiac risk or cancer or anything like that. So there is competing evidence out there. But the vitamin D, not the test, but the supplement, is cheap and safe, and may be a point that we can treat on, which is where the education comes in. My initial thing was, why don't we screen everyone? And then, again, got some pushback from that. So it might just be a matter of education, but still, if more people just realize where we can intervene, where the issues might be, where some of the risks of not treating might be, and then people can make their own decisions.
And one of the key points, as well as like, this should be for us, and so utilizing data of Indian people is going to be particularly useful. Correct. Because while we have to, in the U.S., abide by the United States Preventive Task Force, or we all know that there's deficiencies within that, but utilizing something that may not be applicable to your own population is going to be key. And so just very excited for this initiative to help be part of that data that can eventually change.
Yeah, just for example, one question that was asked was, Jamia and Talibat, when they're getting their health screening, end up low in vitamin D. So what kind of cloth can we come up with that would allow direct sun exposure through their rida? I don't know. How do you answer that, right? But they're at risk.
I had two questions, brief questions. I didn't understand how darker skin or more melanin makes it harder to absorb vitamin D. And the second one, I'm not entirely sure what like menstruation has to do with like bone density loss and stuff.
What your?
Menstruation, like you mentioned post-menstruation and bone density decrease.
So that's with estrogen. So with the changes in estrogen after menopause, the bone mineral density just tends to decrease. Okay. Melanin has just been associated with it. Thinner skin is also associated with it, but the melanin production, I think there's a concept that just blocks some of the light that comes through. Similarly, if you're standing by a window but not outside, you're just not getting as much direct sunlight.
Wow, that's awesome.
It's a really good
It was a great discussion.
And we don't have to say that.
No, I mean,
really good talk.
Yeah. So,
like as a surgeon, that's by far the longest talk I've ever given without the word surgery, but I appreciate everyone's attention.
So I'd really like to thank all of you for this great discussion, and thank Dr. Gomberawala for spending the time and teaching us a lot about this very important, very interesting topic. So
You don't have to do that.
just a small token of appreciation from the board.
Shukran. Shukran, everyone.
At this point, we will break for lunch. Lunch will be in the golf pavilion, which is on this level. There will be signs outside, and there will be volunteers to guide you. For namaz, there is in the downstairs bathroom, Lota and Chaki, there is a room, the Oakbrook room, which has been designated for namaz for those who don't want to go up or don't have a hotel room. Zawal time is at 12:52, so about half an hour from now. We will reconvene back here, inshallah, at 1:30 with an exciting talk on preventing physician burnout.
And if I can add one more thing to those announcements that's super important, there is, inshallah, sometime soon, Shah Saab will be joining us. Is that canceled? All right. Nix that statement. Please go enjoy your lunch.